Okay, as always, folks, when we do our webinars, we are always focused about 3 or 4 main things. Uh, the fundamentals, we call them, of healthy living. To be healthy, it is not about how you feel or how you look or how people say you look or how great people say you look. It's really about what you do, how you control your thoughts, the kind of foods you eat, your lifestyle, and in addition to all that, your understanding of the healthcare system, understanding what is available for you as an individual. And that is what we're going to be talking about tonight. Draw your attention to this book. This is one of our presenters, our guests' books, and I've told you, we had him last time we had him on. He spoke about hormones and healthy aging. Tonight he's going to be talking about fertility, cancer, and fertility. And I was going through his book today, and I read a part of it, and he is, like Sherry said, a wonderful teacher. But here's this really nice quote. In the end, and just as a backdrop, Dr. Greene himself he and his wife, they went through the process of trying to get a baby, and he obviously is going to explain that as he goes along. But in the end, I believe it was the balance we sought after the failed IVF cycle that helped to become pregnant, have a healthy pregnancy, and give birth to our baby girl, who is now 22 months. This balance is what I try to help all my patients achieve. And that is it, folks. The key is balance. The key is balance when it comes to health. But again, with cancer, there's more to it than just balance, because, of course, you're compromised in certain ways. And so Dr. Greene is going to help to explain how this all works and what you can do. You were diagnosed with cancer, and how you can ensure that you have the better opportunity to conceive and carry to full-term pregnancy. So as Sherry reads out his bio and introduces him, I'm going to switch over to you, Robert. And I just want to say thank you again for taking the time to prepare for this presentation.
It's a pleasure, David.
Okay, let me tell you guys a little bit about Robert. Robert Greene, MD, is the medical director of the Schur Institute for Reproductive Medicine in Northern California. He is a sought-after lecturer for healthcare practitioners, from OBGYNs and family practice providers to neurologists and psychiatrists, on subjects ranging from hormonal influences on blood-brain flow, sexual dysfunction, postpartum depression, chronic pelvic pain, migraine headaches, and epilepsy. He is an ad hoc reviewer for Obstetrics and Gynecology, the Journal of Clinical Endocrinology and Metabolism, and the Journal of Reproductive Medicine, focusing primarily on studies involving the hormone-brain relationship, and he's also a member of the American Association for the Advancement of Science. Dr. Greene has published numerous articles in the medical and scientific literature. He has also appeared on NBC's news magazine Dateline, and in the pages of magazines like Self, Glamour, Life Extension Magazine, Cosmopolitan, and Body and Soul Magazine, and the books Women in Overdrive by Nora Isaacs and Menopause and the Mind by Clara Wargay. And he also wrote the foreword to the best-selling book, The Sexy Years by Suzanne Summers. And he was also featured in one of her recent books called Ageless. Wow, Robert, I don't know how you have time to do your normal day job.
Well, that was all before the birth of my daughter.
Oh, there you go.
Well, that's a lot to say about you. And also, I just have to add, he's a really nice guy. So
He really is.
So we'll hand it over to you, Robert.
Thank you. You're too kind. But all kidding aside, what David was referring to earlier, I think, can't really be understated. You know, I actually spent many years giving literally between 80 and 100 lectures per year to healthcare providers, trying to update my colleagues on the latest and greatest information. And the reason I actually started to write books and work with different journalists to get different articles out there and whatnot is I became frustrated at how slowly the information got to the average consumer. You know, science moves at such a fast and furious pace today that I think having, you know, direct access to explain the latest information to the average citizen is really vital. And I really applaud both David and Sherry for, you know, making these opportunities possible so that, you know, we can put information out there and have it available and accessible to people. So thank you both for allowing me to share this opportunity with you.
Well, thank you, Robert. We appreciate it.
Oh, absolutely. And so having said that, what I want to do tonight is I want to try to, you know, summarize what I think is a very, very important and often underutilized aspect of today's medical treatment. That too often today, you know, we see the success of our cancer therapies really helping people go on to live, you know, long, healthy lives post-cancer without enough thought given pre-cancer to how that life might be impacted by the treatment. And what I'm speaking about specifically is how many treatments can have a negative impact on fertility. We do see a larger number of people surviving cancers. We see a very large percentage of our youngest cancer patients having long-term survival. And I think too often the quality of life in a post-cancer lifestyle is diminished if that person at least wasn't given the opportunity to consider their fertility options and their family building options. You know, one of the things I'll share later on, you know, you might even find it surprising that in this era of equal rights, you know, in the process of preparing some of the lectures I've given to oncologists, many cancer survivors are literally not even allowed to adopt children. Many adoption agencies screen cancer survivors out because, you know, they have their own concerns about long-term survival, which makes absolutely no sense at all. And so, you know, not only is it important that many people want to have their own genetic child, but for many couples that may in fact be their only option. So I think this discussion that we're having tonight about fertility preservation is very, very important. In fact, one other point that I want to make is that when I talk to cancer patients, it's amazing the response I get from them, how very often I'll see an expression change in their eyes. And, you know, even though studies show that almost 30% of cancer patients choose not to do fertility preservation, one thing that they almost universally express is the fact that we're thinking about their life post-cancer treatment really reassures them that they really are going to make it through. And so I think, you know, the mind-body influence of giving people that positive outlook of their future, just by opening up the discussion about fertility preservation, may be invaluable and often underutilized, which I think is tragic. So
that's huge. That's huge.
Oh, absolutely. You know, and so, you know, what we're looking at is, and this slide's getting a little old since we do have more recent cancer statistics, but if you look, for instance, in women, if you look at the top 5, I'm messing up there with my pen, Sherry, but if you look at the top 6, you know, most common cancers that affect women, clearly you'll see that 5 of the 6 either affect the pelvis directly or have a tremendous impact on the fertility future for women. Now, one of the interesting things is if you look on the male side, the thing that I think isn't conveyed in a slide like this, which we'll talk about shortly, is that most of the cancers that are listed here as the common cancers in men are actually cancers that don't have as much of a direct impact on reproduction. But the thing that's amazing is there's about 8,000 cases of testicular cancer per year, making it a cancer that occurs with less than 1% frequency, but yet the vast majority of those cancers strike men between the ages of 15 and 40. And even more importantly, nearly 100% of those men that are diagnosed with, men and boys diagnosed with testicular cancer, nearly 100% will become long-term survivors, but very often their fertility future will have been compromised by the treatment that they were given. So I think it's very important that even though testicular cancer doesn't appear to make this list, care because of its impact on the younger patients in particular. Now, keeping in mind just a very, very brief mention that when we talk about chemotherapy, chemotherapies are basically poisons. They're poisons that are administered, and I hope you don't mind me saying that, David, but because they're valuable poisons that the oncologists have given us to attack cancers, but they're poisons that are directed towards attacking the most actively growing cells, which are often the reproductive cells. And they have varying degrees of toxicity, and so this is sort of just a brief summary list talking about which ones are more likely or less likely or simply unknown for how they're going to impact future fertility. Now, similarly, radiation is another cancer therapy that's geared towards rapidly growing tissue. The difference is with radiation, you're not treating the entire person as you are with chemotherapy. The idea of radiation is you focus the beam directly on the area where the cancer is to be treated, but the thing that's important is that sometimes the area is within the pelvis, and sometimes you can shield either the ovaries or the testicles to avoid some of the radiation injury. But one of the interesting things is that cancer radiation treatment to the brain can also have a very long-term damaging effect on fertility, because the brain, the area deep inside the brain, what I call the hormone control center, which is formally known as the hypothalamus, really directs the ovaries to cause eggs to mature and the testicles to produce sperm. And without that signal from the brain, it's a hormone signal that has to go on for many months, you don't get development of eggs or sperm that can create a healthy pregnancy. So, you know, with radiation, we have to think about radiation directly to the pelvis, and we also have to think about radiation more geared towards the brain and whether or not the brain can be affected.
Another I did not realize that.
Absolutely.
I have never, I mean, we never thought about that. That is interesting.
Yeah. Well, and that's exactly why we have to have these ongoing treatments. You know, Sherry mentioned in the introduction that a lot of my research has been interacting with the neurological community. All of my research has been looking at the hormone-brain connection. And this is such a vital connection that for many of my colleagues in fertility, you know, they basically view their center of treatment is from the belly button down, and the absolute necessity is that you also have to consider about what's going on above the neck as well. And we have to integrate that information and come up with a holistic and unified plan.
Got it.
Now, an important point to make, especially when we're talking about cancer survivorship and the impact it has upon fertility, is that with women in particular, not only do we have to look at what impact that the cancer treatment can have, but also just the natural aging process. You know, a woman is born with every egg she's ever going to have, and those numbers go down dramatically. And you can see, as it's noted here, you have at least about a 20% drop in fertility just from birth until puberty. And if you look here at these diagrams, you can see what the ovary looks like from a newborn girl versus a very fertile 25-year-old woman, and you can see how the number of eggs has dropped dramatically. And this is why sometimes some of the most toxic effects of chemotherapy can be when it's administered at a young age, but then similarly, if a woman is given chemotherapy or radiation therapy when she's in her late 30s or early 40s, then you have the additional effect of her treatment superimposed on the baseline effect of just aging itself. And so this is why we have to consider all aspects of the patient's care. And you could see, as this slide reveals, that you could see with a multi-drug regimen of chemotherapy that the chance of just interrupting the menstrual cycles for a woman that's less than 20 is about 50%, whereas if the same patient is over 25 at the time she's given that regimen, her chance of having absence of menstrual cycles is about 80 to 90%. And when you look at the risk of ovarian failure, or, you know, for lack of a more politically correct term, sterility, the absence of any viable eggs, you could see that the risk is roughly about 20% for women less than 20 years of age whereas if the same patient is older, that it may actually be approaching 90% or 90 to 100%. So it's really important that we realize that the effect of the woman's age has a very profound effect on how her body responds to the cancer treatment.
Is this because okay, you mentioned aging,
yes.
but is that because of the increased damage to the cells by the radiation? And I know the woman is born with a limited, a specific number of eggs, about 500, right, for the entire lifetime.
Correct.
And so with radiation and chemotherapy, that's rapidly reduces all that to zero? Is that what you're saying?
Well, it basically dramatically reduces it so that it may not drop it to zero, but it may make it so that the remaining eggs are basically immune to the body's natural signals, and therefore the eggs may remain there but just not viable. I'll go back a couple of slides because one of the things I think is particularly interesting is that even if you look here at this biopsy from a 50-year-old woman, there's still the occasional egg that's in there, but they're just eggs that are no longer considered viable for producing a healthy pregnancy. So, even with the natural aging process, there are still some eggs when a woman goes into menopause. It's just they're markedly less than when she's younger and considered more fertile. And the term that we use in talking about this is a term that we call ovarian reserve, which is just an estimate of how fertile a woman is. And I'll talk a little bit about a simple blood test that we use today to estimate a patient's ovarian reserve regardless of her age. Because we see that some women start out with a better ovarian reserve than others, just like men can have a variable sperm count. Not everyone starts out with the same number of eggs, and not everybody loses them at the same rate.
Got it.
So going on and starting to look at cancer survivor rates, this is a very encouraging slide because look at how many cancers we see that have an 80 to 90% survival rate or better today. And what's so important is many of these are some of the most common cancers that we see and that we diagnose, especially in women of reproductive age. A great example here is if you look here at these 3 bars for breast cancer, you could see for the 3 periods reported, it's estimated today that over 90% of women that are diagnosed today with breast cancer will become long-term survivors. But here's the clincher. Last year, it's estimated that about 16,000 women were diagnosed with breast cancer in the United States when they were less than 45 years of age. And so the important thing is that this is a cancer that we're seeing greater and greater survivorship. Part of that is because we're getting better at diagnosing earlier, but part of that is also because, when we're diagnosing it and treating it early, we also need to realize that these are often women that have delayed childbearing to begin with. We have a lot of women that are waiting until their late 30s or early 40s to even start their families. And so I think it's very important that this issue of fertility preservation becomes very important, especially when we're talking with a breast cancer patient population. Now, when we look at the childhood cancers, there's some important points that we have to make. In 2008, there were almost 11,000 new childhood cancers diagnosed in the United States. And we say childhood, but basically we mean that these are the 18 and younger patients. And as David can attest to, the young cancer patients are often treated with the most highly toxic regimens of chemotherapy. And the good news is you could see that we have a very strong survivorship as a result of that, but it's also very important that we also note that there's often a cost in terms of reproduction. It's been estimated by recent publications that there are currently about 630,000 long-term cancer survivors from this young age-related population in the United States alone. And again, when we start to consider on a more global scale, I'm sure the numbers are much, much higher. I just didn't have access to some of the statistics to provide a more global view. So what are the barriers to reproductive preservation. I think it's very important that we note that the greatest barriers today are related to communication. And I think, in my opinion, that's absolutely tragic. There was a nice study that came out from the University of North Carolina's Fertility Preservation Program a bit over a year ago that found that only about 1 out of every 4 oncologists ever raises this subject with their patients. And to me, that's tragic because, again, this is a subject that patients need to know about, patients want to know about, and I could tell you as a fertility specialist, they tend to be very angry if they find out about it after the fact. And so, giving people a little bit of advance notice is really, it's a good idea for all perspectives. There is, to a certain degree, a lack of awareness amongst the doctors of what options are available. And me, along with many of my colleagues in infertility medicine, are reaching out to oncologists to make sure that they're more aware of this. But sometimes they have difficulty in introducing the subject. And this gets back to what David was saying earlier. This is where the mutual sharing or the Wikipedia-type environment of patients sharing information with other patients, or I should say people sharing information with other people, can be invaluable. When it comes to the cost of treatments, I'll even address that because there's some wonderful organizations that have cropped up to really make fertility preservation accessible to people, even though it can seem expensive when you just consider it as an isolated issue and don't really look at the details of what's available. So having said that, what I want to do is take some time and review the different fertility preservation options that are available. And we'll start off by reviewing some of the ones that are available for male patients, and those tend to be, a little more widely known. But then there's a growing list of emerging options for women, and I want to make sure that we take the time to address some of those, including any of the technical aspects as well. Now, this is really not a slide that I really like a lot. It's kind of a summary slide, and we're going to be going into more detail. But what's most important about this slide is this right here, where the arrow is now, is a great reference that I just wanted to make sure I got this out there so that people can see it, is that the New England Journal of Medicine, which, as David can attest to, is kind of like the New York Times or the Washington Post of medical journals. It's where a lot of the general information that gets widely distributed appears. This is from an article that just appeared a couple months ago, and it's really trying to make sure that the whole medical community, regardless of specialty, is more aware of not only what options are out there, but what options are becoming available and emerging. So if you know a cancer patient or you are a cancer patient, that you have difficulty in raising this subject with your doctor or feel like they might not take you seriously, you can point to this article and just watch their eyebrows go up, and they'll be forced to take a look at it themselves and get informed. So what I want to do now, take a few minutes and really talk about fertility preservation for the male patient. And this is pretty easy, but it's even gotten easier over the last several years. Sperm is able to be frozen very simple, and I could tell you why. It's because it's a very small cell. In fact, sperm is amongst the smallest cells in the entire human body. And the reason for it is that a sperm isn't really much of anything except DNA and a little motor to push it around in. And as a result of that, sperm has very, very little water content. So sperm can be frozen and thawed very easily and maintained, in a very cold storage, with very excellent success rates. And the important point being is this is not a reason for people to freeze sperm at home. I don't encourage that, and I never would. But when it's done properly, sperm can be frozen very, very quickly and thawed with a very good survival rate. And we see now, there was even just a few months ago an announcement of a child born to a man, I think it was 27 years after he froze his specimen before his cancer treatment. And now he's an adult man, and he's got a child of his own. So even though on this slide it says, can be frozen for many years, we know at least 2.5 decades and possibly longer as more of our young cancer survivors use the specimens that they've set aside. Now, what's important is it can be very difficult for most people to get to a sperm freezing lab. And this is a kit that is now available. I'm sure that most cancer patients have heard of Lance Armstrong and his Live Strong Foundation. Through that foundation, people can gain access to this kit called the Live On Kit. And if you go to the, if you either punch in Live On Google or Live Strong, this information comes up. And what happens for less than $600, a kit can be mailed directly to the patient so that the patient can collect the specimen at home and basically arrange for Federal Express pickup or some other overnight service, and that specimen can be sent directly to the lab. It can be tested. It can be stored for, indefinitely, so that that specimen can be used later on. So, this is something that doesn't even require that people leave home. And I can tell you, I had, the experience even just a bit over 2 weeks ago, speaking with a young man that was recently diagnosed with a cancer. And for this young man, it was very difficult for him to even consider going someplace else to collect a specimen, but he found it very comfortable to talk about this, by phone with me, and he expressed his gratitude at having had the opportunity to do this ahead of time. And incidentally, there's even ways of even having the $600 expense offset for people that are financially needy, and we'll talk a little bit further about that a little bit later on as well. In terms of testicular freezing, the concept here is that the testicles could actually be removed and then reimplanted after the cancer treatment. This is an experimental treatment. It's never been tested at this point in human beings. It has been tested and shown to be successful in animals. At this point, it's really just more of a theoretical option that's not really available today anyway. But the reality is when you compare it with the simplicity of simply storing and sending off specimens, I think that it's obvious to everyone concerned that this is much less necessary, especially for the male patients. Another option that can be combined with either of the other two is the idea of suppressing sperm production. And there's a group of medications called GnRH analogs, and there's also the GnRH antagonists. And the idea of these medications is to shut off the signal from the brain to the testicles to basically make them go into a dormant phase so that they're more immune to the cancer treatments that are being utilized. And again, as a review, that chemotherapy and radiation are both treatments that are geared towards killing actively growing cells. And so if you have a means of making the cells become very quiescent and temporarily stop growing, the hope is it would make them more immune to these treatments. Unfortunately, it's great in theory, and it seems much less successful in practice. And as we continue to work to look for better ways of making this more effective, it's something that is an option, but it's not really the best option. It's more of a backup plan. Now I want to focus for the next several minutes on fertility preservation for female patients, because this is arguably much more difficult because of the difficulty that we have in getting eggs that can be handled properly, and then making sure that they're utilized in a way that they can be viable in the future, and I'll talk about that as well. This is kind of a confusing slide, but the point of this is just showing that there are a growing number of options available for women. And I think that any woman that is faced with a diagnosis of cancer should at least have the different options made available to her and discussed, talking about the advantages and disadvantages of each one. And I'm going to go ahead and review them briefly, and my hope is that this just serves as an introduction to greater discussion for patients to have with their doctors. Now, the most common option utilized today is the process of in vitro fertilization, or what's often referred to as test tube pregnancies. And just as a review, what this process involves is a woman is given medication to try to get as many eggs to mature as she's able to give during a specific month, because during any given month, a woman has between 15 and 50 eggs that start maturing. But I tell people it's like a running race, because just like a race, there's typically one winner or occasionally there's a tie. Typically only one egg makes it to be mature, or sometimes two, and that's why women generally only have a single baby or twins on their own. But what we do is we override that process to get as many of the eggs that have started out maturing to get to a phase where they're mature enough that we could then retrieve them. And that this is done through a procedure where we use a needle under ultrasound guidance, and it is done under anesthesia at I'd say at least 95% of centers in the United States, where we actually we aspirate the egg into a test tube, which, by the way, it's the only time the egg ever touches a test tube, and we're able to see how many eggs we get, and then most importantly, we grade them to see how many of them are actually mature, because not every egg is going to be a mature egg, and so we have to see which ones are mature and look healthy. We then go on and fertilize those eggs, and then we watch them, because normally it takes an egg approximately 5 to 7 days to travel from a woman's ovaries into her uterus. What we do is we watch that development in the laboratory, and we could see that by the 3rd day, they tend to look like a cluster of grapes. And then by the 5th day, it's more like a raspberry, where you have a bunch of very, very small cells that are clustered together very tightly. And not every egg that's fertilized will survive to this stage, but the ones that do survive can either be transferred during an IVF cycle, or in the case of fertility preservation, they can be frozen to be transferred later on when the woman has gotten past her cancer treatment and is ready to initiate her family. And so the point is that this is a procedure that takes several weeks, that from the time that the woman starts some medication until she's ready for the egg retrieval. She needs to either have her partner, or she needs to use donor sperm if she doesn't have a partner. And that's, again, if you're going to create embryos. It is done as an outpatient surgical procedure, and this is currently the most effective method for fertility preservation. And again, I'll talk briefly at the end about some of the ways that are available to have these procedures paid for. And again, the point of this slide is that as women age, the success rates for even just becoming pregnant on their own begins to drop. And by contrast, the miscarriage rates rise precipitously. If you look here from age 35 onward, you can see that the rate of miscarriage in red here goes up dramatically. And the reason we understand that is because many of the eggs that women release later on in life tend to be eggs that are at greater risk of having genetic anomalies. But you notice that even in younger women, it's very common for miscarriages to occur at least 15 to 20% of the time. And so it's important that we counsel the patient that not every egg is going to become an embryo, and not every embryo is going to become a baby. And part of what we're able to do today is for patients that really want to know prospectively what their chance of actually having a baby is, we can actually do some of the new genetic testing to actually test the embryo or the egg. And I'm going to talk about that for the next several minutes. David, you may be familiar, I'm sure you're familiar with comparative genomic hybridization, because this is a technique that was first utilized by the cancer specialist to measure the DNA of tumors. And now in the fertility field, we're utilizing the same technique to look at eggs and embryos. And in this slide here, what I'm showing is at the same magnification that an egg, which is 1 cell, versus a day 5 embryo, which is 50 to 70 cells, these are about the same size. But yet here, this is one big cell because an egg has a tremendous amount of water in it. The human egg is one of the largest cells in the body. You can actually see it without a microscope. It looks about the size of a period on a typed page, whereas a human embryo is about the same size, but there are many, many small cells here. This is one of the reasons that it's easier to freeze embryos than it is to freeze eggs, and I'm going to talk about that in just a moment. But in this intermediate stage, on day 3, shown under column B, an embryo is usually between 6 and 12 cells, clustered together like a cluster of grapes. And what we're able to do is we're able to pluck off just one of these cells and do genetic testing if people want to do genetic testing on the embryo before it's actually thawed later on. And here this is showing the process of actually removing one of the cells to undergo genetic testing using an older technique. This is using an older technique called FISH that can test a limited number of the human chromosomes, and there's a maximum of 11 chromosomes that can be tested using this technique. But what we have available today is that we're able to use CGH, or comparative genomic hybridization, to test all 46 chromosomes in an egg or an embryo. Obviously, an egg only has 23 chromosomes because it hasn't met up with a sperm yet. But the point being is that this new test, this CGH, allows us to determine whether an egg or an embryo is going to be genetically competent in order that we can counsel the patient as to what their chances are of getting pregnant afterwards. And this is just a slide to show briefly what CGH involves, is sending off the biopsied specimen to compare the chromosomes to chromosomes that are considered normal. And here you could see is instead of looking at a maximum of 11 genes like you were able to do with the previous FISH study, you could see here that you could test all 46 chromosomes in an embryo, or all 23 if you're dealing with an unfertilized egg. I want to talk briefly about egg preservation because this is much more difficult. You know, in vitro fertilization, the process I mentioned a moment ago, last year alone in the United States, 55,000 children were born through in vitro fertilization. That's not including the Octomom's babies because those were this year. So, you know, the important point being is that I only bring that up because that was a very, very bad choice made by a physician that is currently being investigated for their practice patterns. By far the vast majority of IVF pregnancies today are singleton or twin pregnancies, and you know we've gotten very good at creating healthy pregnancies by minimizing the number of embryos we transfer and only transferring the embryos that are most likely to survive. Across the planet, over 250,000 human beings were born last year with in vitro fertilization. By comparison, 250,000 across the planet, 55,000 in the United States alone.
Wow.
And part of the reason that we see lower utilizations in the U.S. is because many other countries actually include in vitro fertilization in their insurance coverage. So it's kind of a contrast that we deal with here in the U.S.
Which country is most known for this? Which country has the most practice?
I don't actually know. That's a great question. I think it varies. Different countries have much greater access to this technology. And even the way it's used is impacted tremendously by different countries. Like, for instance, in Italy, fertility specialists there are not allowed to retrieve more than 3 eggs at a time, and no embryos are allowed to be frozen. Whereas in England, for instance, they basically just limit the number of embryos that are allowed to be transferred. So different countries have different laws regarding this. So it's highly different.
Mm-hmm. Okay.
When we talk about egg freezing, by comparison, it's been estimated there have been between 500 and 1,000 children born totally through this technique. So, when you compare the high numbers through in vitro fertilization, far fewer when we use unfertilized eggs. And the reason for that is a couple of different things. We understand today that at least 2/3 of all the eggs that are available do not have genetically normal DNA. And so the point being is that at least 2/3 of each egg, 2/3 of the eggs that are produced have almost no chance of becoming a live birth. And so that's why this technique of CGH is so helpful, because what we're able to do, this is a close-up view of a mature egg. And the reason we know this is a mature egg is it's got this structure here that I'm showing with the arrow at the 12 o'clock position, which is called a polar body. What that polar body is that's a 23 chromosome carbon copy of the DNA that's inside that egg. So what we're able to do today is we're able to remove this piece of DNA that the body is in the egg is in the process of getting rid of anyway, and we're able to test that piece of DNA and determine whether or not the egg is normal. And that's much more effective at helping us really select and store only the eggs that we know are most likely to survive. The other thing that makes the challenge of freezing eggs much more difficult is because the egg is the largest cell in the human body, it contains a tremendous amount of water. And when water freezes, it tends to expand, and it can cause things to be crushed. And, you know, if you ever watched a swimming pool freeze in the winter, you could see that oftentimes it'll damage the sides of the pool, or if you ever put a glass jar in the freezer and you went back and saw that it was shattered the next day, you can imagine the impact that could have on the delicate structures inside a cell. So in the past, what had to be done is the egg had to be gradually dehydrated and frozen, and then when you were warming it, you had to try to add back the water at the proper rate in order to ensure the freezing. And it was a very ineffective method of trying to freeze eggs. Today we use this new method called vitrification, and vitrification involves freezing the egg in a nanosecond so that the egg freezes too rapidly for ice crystals to form, and it dramatically improves the survival of an egg through the freezing process. So the combination of being able to genetically test the egg so that you're only storing the ones that are most likely to become a human being, and vitrification, we've got the ability to dramatically improve the ability and the use of human egg freezing. And this is a series of photographs from our lab to show this is the human egg. Here's the egg after that piece of DNA was removed. The egg is going through the freezing process, and you notice how it shrunk between these two slides. And that's, again, you know, it got smaller in the process of actually undergoing the vitrification process. And then here it's being rewarmed, and then here it's actually being fertilized. And again, this is just an example of the new technology that's being available and offered to women. Now, by contrast, there's been a lot of discussion about freezing of ovarian tissue, and this is hopefully something we're going to be able to utilize even more so in the future. Currently, there are only 5 known pregnancies that have resulted from this technology. So by comparison, in vitro fertilization, 250,000 last year alone. With egg freezing, about 500 total. And with ovarian tissue freezing, 5. So you could see that there's a very significant variability in the success of these different techniques. And that's why the freezing of ovarian tissue is considered experimental. One concern that is still maintained, especially amongst the oncologists, is if you're removing a piece of tissue before the person is treated and then you put that piece of tissue back in, how do we know there is not some metastasis from the original cancer that you're going to be placing back when you place that tissue back into the patient? The answer is we don't know. And so that is an additional concern that we have with the possibility of freezing ovarian tissue. And so this is just a side-by-side view of comparing oocyte freezing versus ovarian tissue freezing. Additionally, I want to mention that for limited usefulness, there are some other techniques like ovarian transposition. What this refers to is if a woman has a pelvic tumor, like what Dr. Brewster will be talking about next week, that is warranted for radiation treatment, sometimes the ovaries can be surgically relocated to an area outside the radiation field. And this is something that if time allows and the additional surgical procedures are available, can be done with very significant success as long as the ovaries are truly outside the field of radiation. But again, that's only for pelvic tumors where the radiation is really going to be focused in the pelvis, and assuming there's not going to be additional chemotherapy used as well. For women that have gone through a procedure called a trachelectomy, this is for one of the cancers that luckily we see far less today, a cancer called cervical cancer. This is why pap smears have become so helpful. For women that have undergone this type of surgery for cervical cancer, we do see that many more are able to go on and carry pregnancies after this surgical procedure. And again, it's still considered somewhat experimental because it's a newer treatment that hasn't been available for as long, but it's another effort that is an effort that is well appreciated by the patients that at least have this option offered to them up front. So again, this is only for cervical cancer, which, believe it or not, is probably the most preventable cancer. It's the only cancer that I believe we currently have a vaccine for. Isn't that true, David? The HPV vaccine is to help prevent cervical cancer, and I don't think there's any vaccines for any other human cancers yet.
Right. Not that I know of.
Yeah.
Yeah.
So finally, an additional measurement that we offer and talk about with women, and again, this compares just like with men, is the use of GnRH analogs and antagonists. This is a way of trying to put the ovaries into a very quiescent stage prior to chemotherapy or radiation. And again, this is something that's used with variable success. So, it's not an either-or proposition, but more of an either-and, and that oftentimes this can be combined with one of the other more reliable methods like either egg freezing or embryo freezing if the patient has a partner. Finally, just a couple of mentions about third-party reproduction. This involves using either donated eggs or sometimes having someone else carry the pregnancy. Interesting, not only do surrogacy laws vary state to state, but we actually see a significant number of patients coming from other countries. In some countries in the world, it's illegal for one person to carry a pregnancy for another patient. And so many of those patients actually travel sometimes to us here in California, where we're able to offer some of those treatments more liberally than some of the other more conservative states or countries. When it comes to adoption, I mentioned earlier that for many patients with a history of cancer, that oftentimes they do not have any options for adoption, because many of the agencies, once they know that a patient has been diagnosed with cancer, they will be excluded from the adoption process. And a letter from a compassionate oncologist can often be used to overcome that. And at the very least, most of the agencies do require at least a 5-year post-cancer survival before they even consider people for the adoption process.
Well, they make it very difficult, don't they?
Oh, yeah, they don't make it easy. They don't make it easy. When it comes to children and fertility preservation, when I refer to children, I mean those that haven't yet gone through puberty. Treatments are very limited, and the vast majority of treatments, in fact, all the treatments today for those that haven't gone through puberty are only available in research settings, and so those have to be done through what we call an IRB-approved protocol, meaning a protocol that's been approved by an ethics review board and is monitored by the Center for Disease Control and the National Institute of Health. So I did mention earlier a couple of key organizations I wanted to mention, besides mentioning the Livestrong Foundation, which does a great assistance, especially for male patients that need to do fertility preservation. This organization on top here, called Fertile Hope, not only do they offer educational opportunities, but they have a specific program called Sharing Hope. And in their Sharing Hope program, they basically offer scholarships to patients that are in need of fertility preservation but don't have time to raise capital or don't have insurance coverage to pay for it. And I think the fact that not only do we have these treatments available, but that they're also made accessible through organizations like this, it's really past the time when we don't offer the patients discussion of these important options as we move forward. This third organization here, the American Society for Clinical Oncologists, very important for patients to be aware, because not all oncologists are as progressive as David, and they don't all talk about fertility preservation. This organization published guidelines back in May of 2006 that really stress the importance of including fertility counseling with cancer patients, and this is something that's available at their website. Any patient can print it out and take it into their doctor and request a discussion of fertility preservation if it's not offered outright. And then finally, the American Society for Reproductive Medicine, which is the organization that oversees all of us in the fertility specialty, not only to help advance the science and the awareness, but also to prevent the type of things that you hear about, like the Octomom experience here in California. And again, they're actively involved in trying to prevent any similar events like that from going on in the future. And I can't stress enough that that really is an exception rather than the norm of what happens when patients undergo fertility therapy. I know I've covered a whole lot, and hopefully I've at least touched on all the major issues. And what I'd like to do now is turn things back over to David and see if there's any specific questions we can elaborate on further.
Sure thing. Thank you. Folks, just to let you know, especially if you're new, if you have any questions, you can type them into the box in the panel to your right. In the chat box, you can type in the questions. Thanks again, Robert. This, I know we talked about this before the webinar began, and it was about, I didn't know this. So Lance Armstrong apparently had a lot of counseling, and before his treatment, he had testicular cancer, and did he have his sperms preserved, taken out and freeze-dried the way you've just described? Is that basically what happened in his case?
Yes, he did. In fact, I actually enjoyed his memoir, which I encourage cancer patients to look at. It's called It's Not About the Bike. Of course, Lance Armstrong being a 7-time Tour de France champion in cycling, he actually talks about his experience both with the diagnosis and the treatment of cancer, and he was open and honest and revealing enough to also talk about what it felt like as a single, young, athletic male that had to be thinking about his fertility preservation because someone did, raise the subject for him before he underwent a pretty dramatic treatment.
That's right. Could you show the slide before this one again, the one with the website addresses?
Oh, absolutely.
Okay. One of our guests was asking about that. So the clinical oncologists are now beginning to agree that this is something that should be available to all cancer patients.
Well, it's something that at least needs to be discussed. As I mentioned at the very beginning, there's nothing worse than a patient to find out after they've already undergone treatment that if they had a discussion with you ahead of time that they could have had this option and this option and this option, only to find that those doors were already closed and they weren't even included in the process. And the point being is that studies show that at least 30% of patients that are offered fertility preservation choose not to. And that's fine, but it should be their choice. And at the same time, just being offered fertility preservation is something that can have tremendous therapeutic benefit for just helping the patient realize that, you know what, there really is going to be life beyond cancer.
I think that's a great point you raise. I mean, just that awareness that there is a chance, that not just a chance now, but there's a strong probability that a person will survive. Coming from a doctor willing to discuss that with a cancer patient, that is huge because that communicates to the patient that I'm going to survive. That's why we're talking about babies. I'm going to survive. I think that's huge. That's what hope is all about.
Well, absolutely. And the other thing that's great about the slide that we have up there is that for patients to not only hear it from the healthcare providers, but also to hear it from other patients that have been there and done that. David mentioned that in my most recent book, we talked about what we went through with fertility treatment, my wife and I. And one thing I could tell you is that my patients look at me differently now because they say I've got street cred because I've been through the process. And, the important thing about organizations like Fertile Hope and Live Strong is that even though those aren't healthcare providers, they're people with street credibility as well because they've actually survived cancer and gone on, and many of them, gone on and even raised families as a result of fertility preservation.
Right. Well, it looks like we don't have too many questions here anymore. Apparently, most of our guests have had their kids, and they're okay with what they've got.
Oh, beautiful.
But anyway, thank you for even joining us, folks, because this is information you can share with other people and have let them know that there is a doctor who is involved in this and who is talking about this, and you can always get the MP3s and the CDs from this site. Robert, I know this is part of your passion, but we know you also have other passions that you like to talk about too. For instance, the whole balance thing, the mind-body experience, and the brain, how the brain affects the brain, and the endocrine hormones and the neurotransmitters all affect the way our bodies function. So I know you've been really, really busy, but we're still looking forward to some of those wonderful presentations that you have.
I'd love to do it. Love to do it.
Okay. Well, great. Thank you again, and we just appreciate you for this, and I think we can call this a night.
Beautiful. Have a nice night, Jerry.
Good night, Robert. Good night, everyone.
Good night, Robert. Good night, everyone. Thank you so much again.